Thank you very much,
Sorry,
Mr.
how to minimize the risk of rejection beyond pathology. Sorry.
So thank you very much, Mr. Chairman. I'd like to thank the organizers for inviting me. I'd like to also congratulate the Korean advanced heart failure community for the outstanding success in your transplant outcomes. We're going to change gears here a little bit. I switched with Dr. Ledley so he could get home. I changed the title to Personalized Medicine and Cardiac Transplantation, or what we call precision medicine. If you think about it, everything we do for transplant patients is precision medicine. Everybody's on a different dose of immunosuppression. They may be on different types of immunosuppression, depending upon other factors. I have nothing to disclose. I will talk about the off-label use of Allograft. So what we do in transplantation, as we all know, is a balancing act. We use too much immunosuppression. People develop cancer, drug toxicities, and infections, and too little, and they develop rejection and maybe cardiac allograft vasculopathy. And this shows the variety of steps involved in T-cell-mediated rejection, which is what we're trying to control. But there are a lot of different pathways involved. So I'll discuss in a little while the pitfalls of biopsy, but as we know, it's invasive. Patients hate it. It can damage the tricuspid valve. And it's a technique that was developed in the 1970s to diagnose rejection early. Because before biopsy was available, patients would present with rejection cardiogenic shock, and that clearly wasn't a good thing. So the ideal rejection screening test would be highly sensitive for rejection and adverse outcomes, a negative test strongly associated with good prognosis, a positive test indicates the need for further treatment or further workup like biopsy, non-invasive, easy to do frequently on an outpatient basis, low complication rate, and decreased costs. Now, Dr. Kim from Samsung asked about troponin and BNP. BNP has been studied, and the problem is that there's a lot of overlap in terms of when patients don't have rejection, but they're volume overloaded. Maybe their creatinines are elevated from the calcineurin inhibitors, BNP is elevated. So it's not very helpful. This was a study from Spain looking at high sensitivity troponin T, and while they found that there was an association, it was helpful for identifying the risk for primary graft dysfunction. In their study, they didn't find it to be very helpful for routine surveillance detection of rejection. So one test is the Immuno, which looks at ATP generation in activated T cells. And so if the cells are heavily immunosuppressed, there's less ATP generation. And that means that patients are immunosuppressed. And this shows the scores for patients who have infection are relatively low, for rejection maybe a little bit higher than the stable patients. This has been used mainly in liver transplantation, and it's used as a way of identifying if patients are over-immunosuppressed and at risk for infection. If the scores are low, it indicates you should back off an immunosuppression. This is from the heart transplant data, which is from Cedars-Sinai, comparing steady state to patients with infection, so lower scores, so patients with rejection. Slightly higher, but no significant difference. So we don't use this very often, and people I know who do use this use it as a way of determining whether their patients are over-immunosuppressed. So gene expression profiling has been the way that we've used precision medicine in cardiac transplantation. And there were a number of studies that looked at this. The first was Cargo, which I was fortunate to be involved in, which developed the gene expression profiling test and correlated the results to biopsy scores. So what this looked at was changes in gene expression in peripheral mononuclear cells. And so samples were obtained, and these are the various pathways that were looked at. So it was an 8-center, 4-year observational study, and this number of patients with almost 5,000 post-transplant encounters. So the way it initially worked was blood samples were obtained at the times that patients had biopsies that showed 2R rejection, moderate rejection, or grade 0. And then comparisons were made between gene expression and genes were identified whose expression were increased or decreased at the time of 2R rejection. And the way that the genes were identified was using microarray. Then the second phase was developing an algorithm using 11 genes whose expression changes with rejection, adding 9 what are called housekeeping genes, which are genes whose expression did not change, and so they were internal controls, and then looking at them, at the scores, patients with 2R versus 0 rejection, and then the validation was going forward prospectively. This is what's called a heat map. So these are genes whose expression is downregulated at the time of 2R rejection and upregulated at the time of 2R rejection. These are the genes that were chosen, and so the effort was made to pick a wide variety of genes from different pathways. These are the different pathways. And the bottom line was that molecular diagnostic testing could distinguish a grade 3A or 2R rejection from grade 0. And if you had low scores, the scores are from 0 to 40. If the scores were below 34, you had a high negative predictive value, not over 99% of having a biopsy that did not show a 2R rejection. So in other words, you could use this as a screen, a rule-out test, as a screen for determining who should get biopsied and who shouldn't. And here's the other thing that was very interesting in this study. There was a central pathology core that looked at the grading of the biopsies by the local pathologists, and they found for grade 2R and 3R, where it's really important, they disagreed 62% of the time. They felt that the local pathologists were overgrading the biopsies, which if you think about it is really a serious thing, because what it means is that we're over-treating patients, and we've been doing this for decades. It was kind of chilling to find this out. And the pathologists at all these were all very experienced centers. These are very experienced pathologists, not a bunch of amateurs. So that was that really points to the subjectiveness and limitation of endomyocardial biopsy. So in the United States, AlloMap has been adopted by numerous centers. Thousands of patients have received it. Dr. Hankins and I, when we went to Drexel, were the first to develop an AlloMap protocol that we use to decrease the number of biopsies. And this is it over here. So patients would get the diagnostic score. If it was higher than threshold, they'd get a biopsy. Lower than threshold, they would not get a biopsy. These are the centers that use AlloMap. So there are close to 120 centers that now use it. And these are all the studies that have been done. We'll go through a few of these. So there was a randomized clinical trial led by Mike Pham from Stanford, 13 centers where patients were randomized to be managed with gene expression profiling with the AlloMap or with traditional biopsy approach. It was event-driven, and these were the events, the endpoints: hemodynamic compromise, graft dysfunction, which is defined here, and death for any cause or need for retransplantation. And so patients are randomized to gene expression profiling or endomyocardial biopsy monitoring. And here's one of the issues with the study. Because there was a lot of nervousness about not doing biopsies, the investigators initially did not want to do studies earlier than 1 year. And if you think about it, beyond 1 year, rejection is not very common, so there are low events here. Later in the study, they added patients within the first, from 6 months to 12 months, but only a low percentage. And there was no difference in terms of survival between the gene expression profiling and biopsy-guided groups. No difference in the primary endpoint. So what this meant was that you could manage these patients beyond 6 months using gene expression profiling just as safely and effectively as endomyocardial biopsy. And this was a comment in the Journal of Heart and Lung Transplant where they said, well, maybe we don't need to do biopsies at all. But people weren't thinking that before this study came out. So what about when rejection really occurs in the first 6 months? So the AlloMap was not validated within the first 2 months, and the reason is that 5 of the genes in the panel are very steroid dependent. And so if you're using more than 20 milligrams a day, that alters the AlloMap score. So it really can't be used within the first 55 days post-transplant. The EIMAGE study was similar to the image study I just showed you, but was from month 2 to month 6. And they had similar endpoints, similar design, but started earlier, smaller number of patients. And these were the clinical events. They also looked at steroid weaning. So their threshold was less than 30 did not need a biopsy, greater than or equal to 30 did need a biopsy. And so what they found was that there was no difference in terms of endpoints between the two groups. There was no difference in survival. There were many more biopsies in the biopsy group than in the gene expression profiling group, no surprise. There was a very high negative predictive value and a very low positive predictive value. So even if you have an elevated score, your likelihood of having a rejection is very low. They were able to use gene expression profiling instead of biopsies to wean steroids. This shows how they did that. And they did an IVUS study which didn't show any difference in terms of the IVUS results between the gene expression profiling and biopsy groups. So what this means is that from day 55 post-transplant beyond, you can use the AlloMap in stable patients as a screen for determining whether people should get biopsied. It's always good when another clinical study reproduces the results of your study. So the cargo study was a mainly European study looking at observation of results of scores versus biopsies. And they found a very high negative predictive value, low positive predictive value, same as the initial cargo study. What they did find was the same problem with pathology, that the pathology core, which were very experienced pathologists, differed with the local pathologists 70% of the time for 2R rejection. So just where you need it most, it's not reliable. And they felt that pathologists were overgrading the biopsies. So this is their conclusion. Discouragingly, ISHLT grading is least objective when trying to fulfill one of its main purposes, detection of severe acute cellular rejection, and most objective when trying to prove a negative result, absence of acute cellular rejection, a goal for which it is unsuited because of the possibility of damaged tissue being missed at biopsy. So the ISHLT guidelines for post-transplant management, level of evidence B, which means 1 or 2 clinical trials, class 2A, which means you probably should do it, and there is only one level of evidence A recommendation in the whole guidelines. It turns out that you can get a lot of information from the scores longitudinally. So we did a joint study with Mario Deng at Columbia to look at patients who had variable AlloMap scores versus those who had stable scores. And this is a variable one and a stable one. And what we found was that patients with variable scores were more likely to need retransplant, have death, have graft dysfunction, or have rejection with hemodynamic compromise. Stable patient, unstable patient in terms of the scores. Same here. So this, and when you get an AlloMap, you have the longitudinal display of all the scores. So what this shows the potential use of AlloMap variability to predict the risk of future events while taking into account baseline clinical risk factors. And the Cargo 2 study showed the same thing. Now, another interesting thing was a sub-study of the IMAGE study, where they looked at patients whose scores were below threshold, and they looked at the lowest quartile patients, patients with the lowest quartile scores, so scores under about 28, and compared them to patients in the higher three quartiles. And what they found was that patients with the lowest scores were least likely to be treated for rejection, have any adverse events, achieve composite endpoints, and be less likely to be on steroids. So what this meant was that patients with chronically low scores, you can use this to wean steroids and perhaps other immunosuppression. And we've actually adopted that and have used that to even wean mycophenolate, reduce calcineurin doses. And here's the interesting thing for which I have no explanation, But patients in the immunoprivileged group, and this is a group that's immunoprivileged, were negative for CMV for donor and recipient. Perhaps the presence of CMV ramps up immune activation. It's known in renal transplant that it does that. So, gotta move. And a number of other centers have looked at weaning, immunosuppression. The Mayo Clinic in Scottsdale used this to wean off steroids completely. Does this test predict cardiac allograft vasculopathy? There was a study from the Cleveland Clinic which suggested that AlloMap scores were a little higher in patients with CAV. But, oops, go back. But in a study from the Mayo Clinic Scottsdale looking at IVUS, there was no difference in AlloMap scores. So we do not think that AlloMap can help identify patients with cardiac allograft vasculopathy or with antibody-mediated rejection. It was not designed to look for that. When we did the initial cargo study, there was no ISHLT grading system for antibody-mediated rejection. And it turns out that patients with chronically elevated AlloMap scores are at higher risk of developing cellular rejection or treated rejections. So the caveats, it's not been validated in the first 55 days. You have to use it in stable patients. Somebody coming in cardiogenic shock always needs a biopsy. And you can't use it within 3 weeks of high-dose corticosteroids due to steroid dependence of several component genes. So what's new now? Well, there's an ongoing registry of AlloMap to predict poor outcomes, see if we can use it to predict poor outcomes. But there's something called cell-free DNA. So when cells break down, they release DNA into the blood, and this happens routinely in healthy and diseased tissue. And this was used, we learned this from the obstetricians who published 3 years ago a paper using this to non-invasively detect trisomy 21. And in oncology, they use this, it's called a liquid biopsy. There was just a paper in Nature a few weeks ago where you can identify the presence of metastatic cancer doing this test. And so with rejection, we think there's damage to the allograft and release of donor-specific cell-free DNA. And this would be the pattern. And the early studies were done at Stanford. So there's also been analysis of the Cargo-2 data and of Cargo, which is a kidney transplant study. We'll just go through that. So this is from Stanford, and you see with a 3B or 3R rejection, an increase in the percentage of cell-free DNA. And pre-therapy, there's an increase. Pre-diagnosis of rejection. After therapy, it comes down to baseline. And quiescent levels are lower than rejection levels. And that's true in hearts. And it's true, this is treated rejection. Previously I showed you acute cellular rejection. And it increases a month prior to the diagnosis of rejection. So you might be able to use this to identify patients at risk for rejection. And those would be patients in whom you might alter your immunosuppression, you'd stop weaning, you'd increase calcineurin inhibitors and perhaps mycophenolate and not wean steroids. So this is what happens. And this is again from the Stanford group. And it's true even in kidney transplants. So Dr. Kim, you can tell your husband about this as well. He should be looking into this. So rejection versus quiescent, it's even more predictive than creatinine. And the one thing is, in the first 2 weeks post-transplant, because of ischemia reperfusion, there are high levels, whether it's kidney, lung, heart, or liver. So you have to use it beyond 2 weeks. And here's an example. So the NIH is developing a clinical trial to look at this because this is a marker of injury, any injury, acute cellular rejection, antibody-mediated rejection, perhaps cardiac allograft vasculopathy. And these are the basal levels. This is what we're looking at. So these are 3A rejections and the percentage peaks. And this is an interesting study from the Medical College of Wisconsin, which showed that here a few vasculopathy patients had elevated cell-free DNA. So I think that's the next thing that's going to happen. You see in this patient, when they had antibody-mediated rejection, they had elevations or cellular rejection. So it can really pick up both. And the way, again, this is a rule-in test. If you get this, you biopsy patients. So this may be another test, and it may be combined with the AlloMap, so you can get a rule-in and a rule-out test. So what's in the future? I'm going to go through this very quickly. MicroRNA are small non-coding RNA molecules that regulate post-transcriptional expression of target genes. There are over 1,000 of these, and they're involved in a wide variety of processes. This is an example of one that's elevated in acute rejection. And these are a number of them, and they're numbered based on when they're discovered. But there are a number that are elevated at the time of rejection, and this is how they're identified. And you can find them in the blood. You can find them also in biopsy. So I mentioned the Interheart study, and this is an example from in the biopsy, antibody-mediated rejection and cellular-mediated rejection. And this is in serum. So this is also being studied in clinical trials. And the Interheart is being led by Phil Halloran from Alberta, some of his data. And they use microarrays. Now, antibody-mediated rejection, the biomarker there is donor-specific antibodies. This we've seen from Dr. Hankins, worst grade of antibody-mediated rejection, worse outcomes. And donor-specific antibodies are very helpful to identify patients at risk of developing antibody-mediated rejection. And our current approach to immunosuppression is reactive. Our major focus is rejection, but as we've seen, many patients are over-immunosuppressed. So with this personalized or precision approach, we can alter immunosuppression based on molecular observations. So this is what we're doing now. Endomyocardial biopsy, gene expression profiling, DSA, heart biopsies, and we may be doing some of these in the future. So let me talk about what's really hot and new, which is exosomes. You say, what are exosomes? So this is research that was done by, we call him Dr. V because we can't pronounce his last name. And it's not Korean, but he's one of the most talented surgeons in Philadelphia, and he has a basic science lab. So I don't know how he does it. I think there are two of him. He's been cloned. So he published a paper in the Journal of Clinical Investigation looking at exosomes. And exosomes are, so he identifies biomarkers here. Exosomes express major histocompatibility complex proteins and can be solubilized at the time of injury. So he used this to try to develop a biomarker. And first he looked at xeno-islets, human islets in immunocompetent mice, and found that there was an human exosome signal in mice that were rejecting. And then he looked at blood samples in patients and found the same thing. So we're going to work with him and expand the study to look at larger numbers of patients, but this may be another biomarker. And here's another example of patient pre and post transplant with rejection. So this may be another exciting biomarker. So the point is, so the future studies are study the effects of immunosuppression on acute cellular rejection and try to identify biomarkers that are more precise in terms of being rule-in tests. We already have a very good rule-out test, which is the AlloMap, and identify biomarkers that can identify cardiac allograft vasculopathy. So thank you. Kamsahamnida.